Ma'am, Shweta ma'am has a network issue. So we'll start at 2 p.m. Once Puri sir has joined.
Okay, and then directly we will go to the presentation. Is that right?
Okay, you can share a screen.
You can share screen now. Hello?
Please share, ma'am.
Okay.
Screen is visible.
I'll just try to move the slides for a minute, huh? I can't move the slides. I still can't move this. Oh yeah, I can. It takes 2 clicks. Yeah. So can you just put this bar over? And is it possible to have
Good afternoon, everyone. Can you please confirm Puri sir has joined?
No, Puri sir has not joined right now.
Okay. We'll go ahead with the introductions, and I'll introduce Puri sir and again after the pre-test. Yeah. Thank you, ma'am, for sharing your screen. We can start the recording, Kiran.
Yeah, thank you, Shweta.
Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. Today's topic is HIV-TB, co-infection, case finding, management and prevent tuberculosis. And the speakers are Dr. A.K. Sir, A.K. Puri Sir from NACO and Dr. Upasna Agarwal ma'am from NITRD. We welcome you, ma'am, for today's session. Ma'am, we'll quickly run through the pre-test and then we'll come to the session, please.
Okay.
Is that okay? Kiran, can we have the pre-test, please? Thank you. Participants are requested to please attempt the pre-test. We have 7 questions in all. The pre-test is now visible on your screen. Please scroll through the questions and answer all the questions. Kiran, meantime, please let me know once Puri sir joins the session.
Okay. Ma'am, Puri sir has joined.
Yeah. We welcome Dr. Puri sir to the session. Sir, requesting you to please give the opening remarks.
Okay, thank you. I welcome all the participants from ART centers and other participants and my NACO colleagues. And as you know that it is a very important session, TB and HIV co-infection, how to manage it, how to prevent it, and both the management of the HIV-TB co-infection as well as the diagnosis followed by and the prevention, both are important. And TB is one of the most common opportunistic infection, and the incidence of TB in PLHIV is 18 times as compared to the any other normal people, and this is a very fatal combination. So we need to prevent it and reduce it as much as we can. And I'm happy to note that we have reduced over the last few years with the cross-referral between the HIV and TB, and with the constant coordination between the TB and HIV programs in India, we have brought it down to around 70,000 TB and HIV co-infections. Now the infections are comparatively less. So, dear friends, in this session, we will also be discussing management of TB and HIV-TB in the CLHIV treatment of drug-sensitive TB in 2 phases: intensive and continuation phase, regime for new and previously related drug-sensitive TB patients, and outcome. ART in the PLHIV and TB and co-infection. ART regime in the CLHIV receiving first line various considerations on ART at the time of diagnosis of active TB. Treatment of drug resistance TB in the PLHIV, classification of drug resistance TB, algorithm of drug resistance TB, monitoring of DRTB, and declaration of outcome. Diagnostic tools available for TB amongst the children and its algorithm, and treatment of drug-sensitive TB in the CLHIV. ART in the CLHIV with the TB co-infection, MDR TB, diagnosis, treatment in the children with the HIV situation, based management of HIV and TB co-infection. And general principle of prevention of TB in the PLHIV and ART centers, airborne infection control activity and ART center. Airborne infection, I have seen, it is one of the excellent in Dr. Upasna's center, who is going to take your this session. So now I request her, this airborne infection should not be neglected in anywhere. It is one of the most important things which I have seen, that in majority of the ART centers, I have not seen the proper airborne infection control. That also needs to be taken care of. And she will be talking about that also, the cross ventilation and the prevention and using the mask, and now we are after the COVID time, we are giving more social distancing is being given importance. But even what I have seen in the in that center, it was social distancing was being maintained, queue management, social distancing. These things are very important. So, Dr. Upasna, now I request you to give the brief on these subjects. Thank you.
Thank you, sir. Good afternoon, Puri sir, and thank you for your kind comments. Good afternoon to everyone. And I would now like to request my team to share the screen. So today I will be talking about HIV-TB co-infection, as Dr. Puri sir told you already, and I'll be talking about, I think you have to take down the poll.
Yes, ma'am.
Yeah.
Poll is done, ma'am.
It's done. So can you see my screen?
Yes, ma'am.
Yeah. So today in this NDLS session, I will be talking about HIV and TB. One thing that I want to tell my audience at the outset is that this talk is a little content heavy, and there is a lot of ground that we have to cover over the next 1 hour or so. I will try to be as clear and as precise as is possible with such an expansive topic. And there are certain things that are more important in HIV-TB, which we see more frequently, and certain things that we see less frequently. So I have tried to emphasize on things according to that. So to begin with the session objectives, in this talk, we will talk about introduction to HIV-TB co-infection. We will talk about the general principles for management of dually infected patients. We will talk about management of active TB in people infected with HIV, their adverse effects and adverse drug interactions, the ART regimens that we need to use, and management of children infected with tuberculosis. So if you can refer this back to chapter number 2.8 of the National HIV Guidelines, National ART Guidelines. And in case you want to follow up to read something more about the MDR treatment or the DSTB treatment, then you can also consult the NTEEP. NTEEP is National TB Elimination Program, which is a new name for RNTCP. You can also refer to the NTEEP guidelines for further details. NTEP has different guidelines for drug sensitive and drug resistant TB. So to begin, TB is the most commonest opportunistic infection in people living with HIV. and people with HIV are at 18 times more at risk of developing active TB than people without HIV. TB accelerates HIV disease progression and leads to mycobacteremia. And in India, in 2009, we had an estimated 71,000 incident TB patients among people living with HIV. And we should all know that TB is one of the commonest cause of mortality in people living with HIV. I think I can move the slides. Please, next. So this is how HIV and TB interact, and what basically this slide is telling us is that there is a dual interaction between HIV and TB diseases, and each disease actually worsens the other. If we begin with the first green square, it shows that when a person gets HIV, there is worsening of immune suppression. There is decrease in Th1 lymphocytes and interferon gamma. Basically, cell-mediated immunity is affected. And when cell-mediated immunity is not as strong as before, we know that mycobacterium tuberculosis is one of the diseases that manifests with reduced CMI. So we get clinical TB. Once you get TB, there is systemic immune activation inside the body of the individual due to TB per se. There is secretion of pro-inflammatory cytokines like IL-1, IL-6, TNF-alpha, which in turn would increase viral replication and worsen the HIV disease to AIDS. So basically, this slide just shows a bidirectional interaction. Next. So coming to the general principles for management of HIV-TB next. So basically, there are 4 principles. First is intensified case finding, which is early diagnosis. So the first principle is early diagnosis of TB in HIV people by intensified case finding. Second is prompt and effective treatment of those diagnosed with TB according to drugs and regimens available under the NTEP guidelines. Third is an early initiation of ART and continuation of ART in people living with HIV and with TB co-infection. And fourth is provision of co-trimoxazole prophylaxis therapy in all HIV-TB co-infected patients. So we know this diagram, we have seen it several times, and we have actually instituted forest screening at ART centers for several years now. So this is not a really new thing, but just to complete the list, the early case detection of TB in ART centers is done by a 4-symptom screening tool known as the 4S tool, which for adults is any current cough, fever, weight loss, or night sweats. And for children, it is any current cough, fever, poor weight gain, or reported weight loss, and a history of contact with a TB case. So if a PLHIV or a CLHIV is positive with any one of the 4 symptoms in their category, then the patient is said to be 4S positive. Now, when the patient is 4S positive, what is to be done? And when a patient is 4S negative, what is to be done? We have to remember that this 4S screening has to be done at every visit to the ART center and not only at the initial visit when the patient is registered. So we do it at the initial visits, we do it at the follow-up visits, we do it at unscheduled visits. It is supposed to be done at all visits, because we know the risk of TB is very high in HIV patients, even on ART. So now that you have done the screening, suppose the patient doesn't have any 4S symptoms. So with your 4S screen, you have, with a reasonable degree of certainty, you have ruled out active TB. So now if the patient has not received IPT earlier, or patient is a new case, you will assess for contraindication to IPT. If there is no contraindication, you will go ahead with IPT. If there is a contraindication, you would obviously defer IPT. But suppose the 4S screen is positive. Now, if the 4S screen is positive, there are 3 possibilities. It is TB, it is not TB, or it is some other respiratory diagnosis. If we find out that it is TB, then obviously we will treat for TB. If it is not TB, we will go ahead with IPT. If it is some other disease, then we will give appropriate treatment. And once that is over, we will again screen with 4S and give IPT. Next. So with that understanding that we have done an early effort for active case finding by 4S screening, we look how should the algorithm follow for somebody who is 4S positive. So a person living with HIV who is 4S positive will undergo testing for TB. We all know that the frontline test for is a NACO amplification test, which includes both a CBNAT or a TrueNAT, and different places in the country have TrueNAT and different places have CBNAT, but essentially both of them are NAT tests. So if we have a NAT positive MTB, that is, we have a sample, the easiest sample being a sputum or a FNA or probably a CSF sample. or some other clinical sample which can be put up for NAT. So we put that up for NAT. Now, if MTB is detected in that NAT test, then we have, of course, we have TB, we have active TB, but now there are two options. It could be RIF resistant or it could be RIF sensitive. If it is RIF resistant or NAT, then we have to refer this case to our nearest drug resistant TB center, which is basically the DTO now, where he will undergo a first line, second line liquid LPA and liquid culture, and ATT will be decided by the DRTB center. Now, if it is a rifampicin sensitive TB, then we will center. But we have to remember that a NAT does not give us the sensitivity of INH. And we have to know the sensitivity of INH also if we have to put them on a correct first line regimen. So we send a sample for a first line LPA, which will give us the information about whether the patient is INH resistant or not. If INH resistant, then again we have to refer the patient to the nearest DRTB center for a different ATT regime considering the INH resistance. If the patient is INH sensitive, we will continue ATT and at the ART center. Now coming to the right hand side limb of this algorithm, suppose NAT is negative, or we were not able to get a sample. We are not able to get a clinical sample. It happens very often in extrapulmonary cases. So what do? We cannot say it is not TB or TB. That doesn't mean if we don't have a sample or NAT is negative that the person does not have TB. So we will evaluate for TB using other appropriate diagnostic tests. We will do an X-ray. We'll do an X-ray for smear negative pulmonary TB. We will do an ultrasound abdomen. We would possibly look for lymph nodes, and we would do other tests as would be demanded by the symptoms of the patient or whatever extrapulmonary site seems to be the cause for the symptoms. If TB is diagnosed, we start ATT at the ART center. If TB is ruled out, we evaluate for alternate diagnosis. Next. Now, this is about early detection, and it is also about how we will go about diagnosing. So, picking up presumptive TB, diagnosing presumptive TB to actual TB. And now, once you have a case of TB, because we manage, diagnose, and investigate TB in our ART centers within the purview of NTEP guidelines, then all our definitions also have to be in line with the NTEP guidelines. So TB under the NTEP can be classified into different types based on different criteria. So if we look at the criteria of microbiological confirmation, microbiologically confirmed TB is one in which a presumptive TB patient has a biological specimen which is positive for AFB on microscopy or MTB on culture, or has a positive rapid diagnostic test like NAT or LPA. While a clinically diagnosed TB case is one in which a presumptive TB patient does not have any microbiologically confirmation from any sample, but is diagnosed with active TB by a clinician based on X-ray, histopath, or clinical signs with the decision to treat with a full course of ATP. Excuse me. Then in children, clinical diagnosed TB does not only depend upon clinician based on radio, it will also depend upon exposure to an infectious case, evidence of TB infection possibly by a positive TST, and clinical findings suggestive of TB in the event of negative or unavailable microbiological results. Now, depending upon the anatomical site, there can be a pulmonary TB. Pulmonary TB is when TB is of the lung parenchyma or the tracheal bronchial tree, and extrapulmonary TB if it is of any organ of the body other than these two. Next, we have to remember that miliary TB is pulmonary and pleural TB is extrapulmonary. Now, based on history of previous antitubercular treatment, the TB case can be classified into a new case. A TB patient who has never had treatment for TB or has taken anti-TB drugs for less than 1 month is a new case. So 1 month is the cutoff. Less than 1 month ATT or no ATT, new case. If taken treatment for more than 1 month in the past from any source, it is previously treated. Now, recurrent case is somebody who is a TB patient. He was previously declared successfully treated, and subsequently he's found to have another episode of active TB, and this time also it is microbiologically confirmed. So this is recurrent case. A treatment after failure is treatment of a patient who gets TB after he has failed his last episode of treatment with TB for TB. Treatment after loss to follow-up is a TB patient previously treated for TB for 1 month or more and was declared lost to follow-up in his most recent course of treatment. And others basically means all other previously treated patients who do not fit in the above three categories. For example, you can have a TB patient who was previously successfully treated and subsequently he has TB, but it is not a microbiologically confirmed TB. So he cannot be called a recurrent case. So then he would be in the category of others. Next. Now we come to based on the criteria of whether the bacilli of the patient is sensitive to first-line drugs or not. Now, this is very, very important information that the clinician needs to have before he starts planning the treatment of a patient who is diagnosed with TB. A case is said to be having drug-sensitive TB if his MTP is susceptible to all first-line drugs, which are rifampicin, INH, pyrazinamide, and ethambutol. And a case is said to have drug-resistant TB if he is seen to be resistant to any one or more anti-TB drugs, basically the first-line drugs. And multi-drug resistant is only labeled. It is a subset of DRTB. A patient is only labeled to have MDR-TB if the TB bacilli are resistant at least to both INH and rifampicin, with or without resistance to other first-line drugs. Next. So with this information, now we have suspected TB, now we have diagnosed TB, and now we have classified TB, and now comes to the treatment. So firstly, we are talking about treatment of drug-sensitive TB. So in drug-sensitive TB, whether it be a new or a previously treated case, the ATT remains same that is given for HIV negative. And the treatment given is 4 drugs in the intensive phase. This intensive phase is for 8 weeks, 56 daily doses of HRZE. Under NTEP, this HRZE is given as a fixed dose combination by the name of 4-FDC. So 4-FDC, 56 doses. Then we shift on to the continuation phase in which we use 3 drugs. Pyrazinamide is stopped and we have HRE, and this is given through the fixed dose combination known as 3-FDC, and 3-FDC is given for 16 weeks, a total of 112 doses. Next. This is the weight-wise chart. So these are the weight bands, which on basis of which you would decide how many tablets of FDC4 or FDC3 are to be given to a patient. For example, if a patient is a 45 kg, then it comes in the weight band, the second weight band. So in such a case, we have to give 3 tablets of 4-FDC in the intensive phase and 3 tablets of 3-FDC in the continuation phase. The main points to remember here are that this chart is for adult patients, for TB patients more than 18 years who get active TB. If there is a PLHIV who is less than 18 years, then the chart for him, the weight-wise chart for him would be that of pediatric cases. If the weight of the patient increases by more than 5 kg and crosses to the next weight band, it has to be both 5 kg plus crosses to the next weight band, then we should shift to the number of FDCs as are defined in the higher weight band. Loose TB drugs are available and should be used for substitution in case of adverse drug reactions. And streptomycin is now no longer a second-line drug. Treatment of candidiasis with fluconazole is a common concomitant illness with TB, and very often we have to give fluconazole with ATT. So please remember that can lead to liver function, hepatotoxicity. Next, please. Now, after we have talked of treatment, comes follow-up. Clinical follow-up is easy. It should be done. There is no option of missing out on clinical follow-up, because sometimes that is the first thing that gives you an idea that the patient is not doing well. It should be done on all the monthly visits. You should look for improvement in clinical symptoms and increase in the weight. And you should also look whether any comorbid conditions are there, like diabetes, which need to be controlled. And we should keep on screening the patient on every monthly visit for symptoms and signs of adverse reactions. Now, the other component is a laboratory follow-up. Laboratory follow-up would mainly be for cases of pulmonary tuberculosis, and that would be examination of sputum by microscopy at end of IP and at completion of treatment. That is at end of 2 months and end of 6 months, or in the last month of treatment. Please remember, follow-up is never done by NAT test, because NAT test is a nucleic acid test, And a nucleic acid test can pick up DNA from a dead bacteria or dead bacilli and give you a positive test and does not actually provide information of the current health status of the patient. Next. To this, I would like to add that we could also do a radiological diagnosis for patients who have been diagnosed on basis of probably ultrasound or CT chest or MRI. And then you can probably do scheduled or screening radiological investigations to look for these extra response in these extrapulmonary sites. So with this, we would now come to adverse effects and drug interactions of anti-TB drugs. Looking at the first line drugs, isoniazid, rifampicin, pyrazinamide, and ethambutol. I'll discuss here the main effects. The main effect of isoniazid is peripheral neuropathy, to prevent which we give B6, then skin rashes, hepatitis, and lethargy. With rifampicin, the most common side effect is GI intolerance. The patient is not able to tolerate the drug. There is vomiting, nausea, abdominal pain, and there can also be full-fledged hepatitis with some cutaneous reactions and thrombocytopenic purpura. Pyrazinamide causes arthralgia, joint pains, hepatitis, and GI intolerance, while ethambutol causes retrobulbar neuritis. Next. Now, this was enumeration of the side effects according to the drug. But the patient will not come to us according to, he will not come and say that I have side effect to INH. He will actually give us a symptom. Now, with that symptom, we have to try to identify what is the culprit drug in the anti-tubercular therapy, which should be tackled in case of this symptom. So if a person who started on ATT starts complaining of upper abdominal pain, nausea, and vomiting, it is GI intolerance, which can be seen with any of the anti-TB drugs and is usually managed with NSAIDs and PPIs and probably giving them a light meal before giving the tablets. Other could be a frank jaundice, that is nausea and vomiting with yellowness or indication of jaundice. This is mostly caused by pyrazinamide, rifampicin, and isoniazid. So these would be the most possible culprit drugs. And it can be one or all of these drugs which are responsible for this jaundice. Then there can be itching and rashes. In that case, there would be ethambutol, rifampicin, and streptomycin. These rashes can be very serious, and once again, the same drugs would be responsible. A patient can come to you with tiredness, lethargy, looking pale, palpitations, exertional dyspnea. So it is basically due to anemia. So anemia is mainly seen with isoniazid and sometimes with rifampicin and pyrazinamide. ER toxicity, kidney toxicity, giddiness is basically seen with streptomycin and other aminoglycosides, but streptomycin is now no longer considered as a first-line drug. We can also see some giddiness with isoniazid, and isoniazid can also lead to tingling and burning and numbness in the hand and feet, which are basically symptoms of peripheral neuropathy, and sometimes other CNS symptoms like convulsions or psychiatric disturbances. Next. So with this information about side effects and how potentially the side effects could present to us, let us have a look at what would be the drug-drug interactions of anti-TB drugs with ART. The main drug in first-line anti-TB drugs, which can cause a drug-drug interaction with ART, is rifampicin. And the other rifamycin is rifabutin. Rifampicin being a very potent CYP inducer, it interacts with protease inhibitors, with NNRTIs, nevirapine, with antifungal azoles, with oral contraceptives, with methadone, with Taxol. So we prefer not to use rifampicin when the ART contains a protease inhibitor or nevirapine. In case of rifabutin, it is also a rifamycin, but it is not that potent a CYP inducer. It is a very mild CYP inducer. So in these cases, whenever we have PIs in the ART regimen, we would prefer to give rifabutin instead of rifampicin. But we do not like to give rifabutin with nevirapine because of the hepatotoxicity risk. Next. So what can be given with what? So this is the chart of combination and permutation. So if on the ARV side, if you have an NRTI, that is zidovudine, tenofovir, lamivudine, you can easily and comfortably give rifampicin no interactions, and if required, rifabutin. If for some reason rifabutin is to be given, that can also be given. With efavirenz, you can give both rifampicin and rifabutin. With nevirapine, we would not prefer to give rifampicin or rifabutin, and if nevirapine is indicated and NNRTI is indicated, we would like to switch to efavirenz rather than giving nevirapine and try to retain our rifampicin. Now with boosted PIs, rifampicin is not to be given because of drug interactions. Instead, we will prefer rifabutin 150 milligram daily. With dolutegravir, we can give both rifampicin and rifabutin. But if we give rifampicin, we have to give an additional dose of 50 milligram daily along with the regular dose. And if we give rifabutin, we do not need to give this extra dose. With raltegravir also, we can give both rifampicin and rifabutin. But again, with rifampicin, we have to double the dose of raltegravir, which we do not need to do with rifabutin. Next. Now we need to know about this one particular side effect, drug-induced hepatitis, which is the commonest problematic side effect that we see in our ERT centers. Among all the side effects, we decide in this NDLS, we want to discuss in a little brief about hepatitis because that is something that really is a problem for our ART centers. So what is drug-induced hepatitis? We have to understand that transient asymptomatic increases in serum liver aminases always occur during the early weeks of treatment with anti-tubercular drugs. For these, we do not need to stop drugs or do anything. But in case the serum liver aminases are more than 5 times the upper limit of normal, or there is a raised serum bilirubin, even without symptoms, or there is a raise in serum liver transaminases up to 3 times the upper limit, accompanied with symptoms. So a symptomatic mild increase in serum liver aminases, any increase in serum bilirubin, and more than 5 times increase in serum liver transaminases comprises an indication of drug-induced hepatitis with ATT, and all drugs are to be stopped. We should also keep a lookout for acute liver failure. Next. Usually it doesn't progress to acute liver failure, but it is important to know at the back of your mind that if you do not stop drugs in a timely manner, the patient might land up into acute liver failure and it can be fatal. So now what are you to do? You are to stop all the drugs and manage ATT drugs and manage the patient conservatively and wait for the patient to recover from jaundice. Next. We will talk about this a little later. So coming back to hepatotoxicity, once you have stopped the drugs, given the patient time to recover, his liver enzymes have returned to 2 times the upper limit of normal. He is no longer symptomatic. You can actually reintroduce your anti-tubercular drugs. You can reintroduce all the drugs together the first time. But if once again the patient gets hepatotoxicity, it is advisable to refer the patient to a specialist, your internal medicine OPD or your TB specialist for reintroduction of anti-TB in hepatotoxicity. Similar is the case for rashes. In certain cases, the patient would have rashes. You would manage the patient with probably antihistaminic, steroids, topical ointments. The rashes subside, you reintroduce ATT, and again the patient gets rashes. So in such case, the drugs have to be introduced one by one, which we will talk about in the next slide, and it is better to refer to a specialist. However, in cases of ocular toxicity, immune-mediated nephritis, serious cutaneous adverse reactions, immune thrombocytopenia, aplastic anemia, ototoxicity, and diarrhea, we should not reintroduce the culprit drugs. As far as nephrotoxicity is concerned, as I just informed, that it is aminoglycosides which mainly cause nephrotoxicity. They are no longer used in the first-line regimen. Streptomycin is rarely used in the is no longer a first-line drug. But in case you have to use streptomycin and the patient has deranged kidney function, then we will calculate the creatinine clearance. Can you go back? Using the equation that we have here. Can you see the last part of the slide? The Cockcroft-Gault formula with which we will calculate the creatinine clearance ahead. It is calculated separately for male and female. Next. And accordingly, we will give our anti-tubercular drugs. For streptomycins, we would probably totally avoid them. And if the creatinine clearance is less, then we can safely give our rifampicin and INH in the regular doses but ethambutol and pyrazinamide has to be shifted to 3 times a week. Next. This is the chart which shows how you have to introduce one drug at a time in case of hepatotoxicity or recurrent rashes. So when you introduce isoniazid, day 1 give 50 milligram, day 2 give the full dose of 300 milligram. If tolerated, go on for the 3rd day. If tolerated, reintroduce rifampicin on the 4th day. When you introduce rifampicin, introduce with 75 milligram, then if tolerated 300, if tolerated full dose, if tolerated 4th day, go on to pyrazinamide, 250,000 full dose. If tolerated, go on to ethambutol, 100, 500 full dose. Thank you. So now you have treated the patient, you have looked after the side effects, you have done everything that was required to do. And now you have followed up the patient. Now you have to declare an outcome at the end of 6 months. So what are the treatment outcomes? One treatment outcome is cured. For that, you need a microbiologically confirmed TB patient at the outset of treatment, who at the end of treatment is able to show a negative culture or a negative smear. But suppose you did not have a microbiologically, so that would be a cured patient, but suppose you did not have a microbiologically confirmed TB patient first, you had a clinically diagnosed TB patient, and now at the end, obviously the only way to monitor, there will be no microbiological evidence at the end of treatment, so this would be treatment completed. Also, if a microbiologically confirmed TB patient does not have a negative result at the end of treatment because it is unavailable or it is not done or sputum is not produced, then also that patient will be taken as treatment completed. Both cured and treatment completed compromise treatment success. Next. While failure of ATT would be a TB patient whose biological specimen is positive by either smear or culture at the end of treatment. Failure to respond is something that we have in children. A case of pediatric TB who fails to have microbiological conversion to negative or fails to respond clinically or deteriorates after 12 weeks of compliant treatment shall be deemed as failed response. A lost to follow-up TB case is one whose treatment was interrupted continuously for 1 month or more. Not evaluated is basically patients who were transferred out in the middle of ATT and their results are not available with you. Treatment regimen changes, a TB patient who is on first-line regimen and has been diagnosed as having DRTB and switched to drug-resistant TB prior to having been declared failed. For example, if you start a patient on the basis of CBNAT R sensitive on first-line drugs, but then your first-line LPA shows that the patient is H resistance and you shift the patient to a second-line regimen. Died is a patient who has died during anti-TB treatment. Next. So this was about ATT. Now coming to the ART in a person who is co-infected with TB. ART should be started, as far as the timing is concerned, ART should be started as soon as possible within 2 weeks of initiating TB treatment, regardless of CD4 cell count among people living with HIV, except where signs and symptoms of meningitis are present. Among PLHIV with TB patients, ART should be delayed for at least 4 weeks, but within 8 weeks after treatment of TB meningitis is initiated. And corticosteroid should be used as an adjuvant. The reason for singling out TB meningitis is that with partially treated TB meningitis, the risk of serious iris and the patient taking a turn for the worse is very high. So except for the exception of TB meningitis, we should try to start all our patients on ART within the first 2 weeks. Next. Now, what would be the ART regimen that you would give for a HIV-TB co-infected patient? For an adult HIV patient who weighs more than 30 kg, it would be TLD with an extra dose of DTG 50 milligram in the morning, while TLD is given in the evening for the entire duration of ATT. We also have to remember that the additional dose of DTG is to be continued for 2 weeks after completion of rifampicin-containing ATT. And after 2 weeks have elapsed, then we can go back to our single tablet DLT. For an adult patient with weight less than 30 kg with ATT, it would be abacavir, lamivudine, and dolutegavir, again with an extra dose. And in both these cases, the ATT remains same, that is 2 HRZE plus 4 HRE. Now, with a person who has higher serum creatinine, we will use abacavir, lamivudine, and dolutegavir 50 milligram. And the ATT that we would use would be 2HR, and Z and E will depend upon what is the creatinine level. If the creatinine clearance is less than 30, then we will have to give Z and E on 3 alternate days. In women of childbearing age, we would give TLE and the same standard ATT, but we can also give TL and lopinavir ritonavir. Rifampicin must be replaced with rifabutin if we are choosing a lopinavir ritonavir regimen. Next. Now, what to do if a patient is already on ART and then develops TB? Then, in case whether he is on zidovudine, tenofovir, or bacavir, and he's on a dolutegavir-based regimen, then we continue the same ART but add an additional dose of dolutegavir, and we continue the standard first-line ATT. If the patient is on an efavirenz-based regimen, then also we do not need to change the ART regimen, and we continue the same standard ATT regimen. Next. Now, if the patient is on a PI-based regimen, then in case of a PI-based regimen, we will have to modify ATT, and we would have to give rifabutin 150 milligram with the anti-TB treatment if we are unable to change the PI. But if the patient is not resistant to DTG or is not DTG experienced in the past, we can very well change this regimen to a DTG regimen. And then once we change it to a DTG regimen, we can give the standard ATT with an extra dose of DTG. Suppose the patient is on the third line regimen, PI plus DTG, then this would require both. It would require an extra dose of dolutegavir and also replacement of rifabutin, of rifampicin with rifabutin in the anti-TB treatment. Next. Now coming to the issue of drug-resistant TB and PL-HIV. So they are said. So basically, resistance can be to one drug, monoresistance. It could be only INH, it could be only rifampicin, it could be only any other drug, or it could be polydrug resistance, in which more than one patient's bacilli is resistant to more than one drug. Next. As we explained earlier, MDR-TB is a subset of DR-TB in which the biological specimen is resistant to both isoniazid and rifampicin. Now, if a patient of MDR-TB that is resistant to INH and rifampicin is also resistant to any fluoroquinolone, which is a second-line anti-tubercular drug, then the patient becomes a pre-extensively drug-resistant TB or pre-XDR-TB. And if there is another add-on resistance, like patient is resistant to INH and rifampicin and any or all fluoroquinolones, and also to one additional group A drug like bedaquiline or linezolide or both, then he becomes XDR-TB. So this is the minimal requirement for classifying somebody as MDR, pre-XDR or XDR-TB. Along with this, there can be any number of other resistances in the bacilli. Next. So I would really, let's go to the next slide. So I would really not like to go in too much detail of this, but it is sufficient to say here that all second-line anti-tubercular drugs are classified into 3 groups, group A, B, and C, and these are according to their efficacy. As you go down, the efficacy goes down. And this grouping helps the TB physicians to make a second-line anti-tubercular regimen for patients with complex resistance patterns. The reason we need to know a little about these drugs is because HIV patients who would be coming to our centers would be on these drugs if they are a case of DR-TB. So we should know that a person of DR-TB would probably be on a fluoroquinolone, which can cause seizures, headache, or QTC prolongation. The new drug bedaquiline can cause hepatotoxicity, QTC prolongation, or dyselectrolytemia. Linezolide is very famous for causing peripheral neuropathy and bone marrow depression anemia. It is very, very famous for causing that. Then clofazimine can discolor the patient's skin. The patient can suddenly become darker than the patient was earlier. Cycloserine can cause CNS symptoms like psychosis and depression. Next. Ethambutol, we know ocular toxicity. Delaminid, another new drug, can cause QTC prolongation and cardiac toxicity. Pyrazinamide, again joint pains. And we know that streptomycin and amikacin can cause hepatotoxicity, oxytoxicity. Ethionamide and PAUS are also used as second-line antitubercular drugs, and they can cause hypothyroidism and severe gastritis in a HIV patient on second-line drugs. Next. So this is the integrated drug-resistant TB algorithm. It is taken from PMT guideline 2021. The only thing I have to tell you in this is actually the limbs of the algorithm have got interchanged. So what we are seeing on the right side is actually what should be on the left side, and what HIV person, and we get a CBNAT done for that person, and rifampicin resistance is not detected, then it is our regular TB that we are seeing in our ART centers. We start the patient on DSTB regimen at the ART center, and what do? We send the patient for first-line LPA. If H resistance is not detected, we continue with the DSTB regimen at the ART center. If H resistance is detected, then we continue. Then we send the patient to a DRTB center. Now coming to the second limb, if resistance is detected, the patient automatically goes to a DRTB center, where the patient undergoes a first-line LPA, a second-line LPA, a liquid culture DST. Next slide. And following all these tests, the patient is put on one regimen or the other. They are different regimens. I will not discuss the details of the regimen. There is a shorter oral bedaquiline regimen. There is a longer oral MDRX DRTB regimen. And now we also have a B review of this talk. Next. This is again the same thing, shorter regimens, shorter injectable regimens, longer oral regimens, and now a BPAL regimen. Next. This is also similar. So it is again, actually, it is the same thing again. Next. So once a patient is diagnosed as DRTB, the monitoring follows sputum and microscopy is usually done by the NTEP or the district TB center staff. And it is the NTEP staff which also gives the outcome of DRTB as cured, treatment completed, failure, not evaluable, regimen change, loss to follow-up, or diet. Next. So now that we have talked about the ATT, the second-line ATT, we also need to talk about what ART to be given. We have to understand that bedaquiline, one of the new antitubercular drugs, which is a second-line TB drug, and delamanide, both these are new drugs. They can be safely given with a DTG-based regimen. And this time, because there is no rifampicin in a second-line ATT regimen, we do not need to give a double dose of DTG. It will be a single dose of DTG with second-line antitubercular therapy because there is no rifampicin. However, if the patient is on a PI-based second-line or third-line regimen, in such cases, we would actually prefer delamanid and not really prefer bedaquiline, because the evidence with bedaquiline and PIs is very limited, and we are still not sure of what kind of drug interactions or side effects can happen. So in such a case, delamanid is the preferred choice. And if in case there are no drugs left and we really have to use bedaquiline, then it is not an absolute contraindication. You can use bedaquiline, but we will have to use it with a lot of caution. Next. So this was all about adult TB. Now briefly coming to TB in CLHIV in children. Next slide. In children, we know that children who are infected with HIV can have primary progressive TB, can have more EPTB, multi-drug resistant TB, and have a higher case fatality. We have also discussed that the poorest symptom tool is fever, cough, and weight loss. Weight loss or inability to gain weight. Weight loss is defined as more than 5% body weight loss when compared to the highest weight in the last 3 months. And what is poor weight gain? It is no weight gain in the past 3 months. And the fourth point is a contact with a TB case. Now, what is a correct contact? The correct definition of contact with a TB case is contact of the child with a person with any form of active TB within the last 2 years. So if you have one of these 4 symptoms, the patient is porous positive, then there can be some additional clinical features like a lymph node enlargement, a headache or confusion, backache, joint pain, chest pain, respiratory distress, abdominal pain, which can point towards extrapulmonary TBs like brain TB, bone TB, pericardial TB, abdominal or peritoneal TB. Next. So evaluation of children remains essentially the same as in adults, except there is a very important step here that I would like to discuss. If there's an HIV infected child who is 4S positive, according to the 4S for children, then he becomes a presumptive TB case. In such cases, we have to get the child examined very carefully by a medical officer or a pediatrician, for the simple reason that children in India have a lot of short illnesses, short respiratory illnesses, short febrile illnesses, tonsillitis, virals, which would be the cause of their 4S positivity. And we do not want to commit all children to TB investigations unnecessarily. So once a medical officer has ruled out or has treated and followed up a patient with any short febrile or respiratory illness, then the patient and the patient continues to be 4S positive, then we will say that yes, it is a presumptive pulmonary TB case in a child. A CB NAT and X-ray will be done, and based on NAT result and X-ray, we will define whether the patient is. If the patient is NAT positive or culture positive, it is a microbiologically confirmed TB. If the patient is NAT negative but chest X-ray positive, then it is clinically diagnosed. And what is a chest X-ray positive for TB? A chest X-ray highly suggestive of TB is having miliary shadows or lymphadenopathy or chronic fibrocavitatory parenchymal lesions. And if both chest X-ray is not suggestive of TB and NAT on smear are also negative, then we should look for some other diagnosis, or we should say that it is not TB. In case we are thinking of a presumptive extrapulmonary TB, in which X-ray is normal, NAT is negative, then we would have to look at other sites of TB like a lymph node, CNS, spine, abdomen, like we just discussed. And we should try to get a biological specimen. A biological specimen, even a sputum in children, is very difficult. So at times we have to send them to a pediatrician to get induced sputum or gastric aspirate. But in case if we can get an FNA or a pleural sample, we should send it for NAT, smear, and culture positive at one go, because it is a precious sample. We should also get the extrapulmonary sample examined for cytology and histopathology and other relevant radiological tests. And based on this, if they are suggestive of TB, a diagnosis of extrapulmonary TB should be made. Next. Can you see the screen?
Screen is visible, but slide is in not in full screen mode. Please make
full
it.
screen mode. Can you see it now?
No.
Okay, so we will share the screen again. Please give us 1 minute.
Okay.
Can you see it now?
Screen is visible, ma'am. Please make full screen mode.
Achha, full screen we are trying, but somehow we are not able to.
Right side.
Yeah, we did that. We did that. Okay. Now I make it full screen. Can you see it now?
No, ma'am.
So can we continue like this, or because it will? Close this.
I am trying to my side. Just.
Okay, no, our person from ECHO is doing it. So I think both of us will both start doing. So just to tell about this chart, this green and blue chart, I think. Can you see it now, or is it still in the?
Not in the full screen mode, ma'am.
यहाँ से full screen करने से नहीं आ रहा है. Now?
No.
No. Okay. आप वहां से share कर दीजिए, please. Please share it from your end. I-Tech. Mr. Kiran. Can you share? No.
Ma'am, it is visible.
I can't see it, but what I can do is, yeah, I can see it now. Have you shared the screen, Mr.? Can you see it now, Mr. Kiran?
Yes, I have shared from my side.
So it is now visible. Is that right?
Yes.
Yeah. So now sorry for the interruption. Actually, it's such a long content heavy talk. Anyway, so this is the pediatric chart, which tells us for how much kg we should use how much tablet of 3 FDC and 4 FDC. Again, the treatment remains same. HRZE in the intensive phase and HRE for the continuation phase. 8 weeks of intensive phase and 16 weeks of continuation phase. And this is to be used for all PLHIV who are less than 18 years. Next, please. Next slide, please. Yeah. So now coming to what would be the ART in children living with HIV. If the weight is less than 20 kg and age less than 6 years, it would be abacavir, lamivudine, and lopinavir, ritonavir with super boosting with additional ritonavir. So as to compensate the effect of rifampicin. If the weight is between 20 and 30 kg and child is between 6 to 10 years, it would be abacavir, lamivudine, and dolutegavir with a double dose of dolutegavir. If weight is above 30 kg and the child is above 20 years, then it will be TLD with an additional dose of dolutegavir. And in children also, we have to continue dolutegavir for 2 weeks after stopping off rifampicin containing anti-TB treatment. Next slide, please. So now coming to NDR-TB in children, I would seriously suggest that this is a diagnosis to be made by a specialist. But suppose you have a child with you whom you started on DS-TB or whose rifampicin or whose CBNAT came out to be rifampicin resistant, or somebody on DS-TB who's not doing well, I would really request you to suspect that the patient has the possible probable DR-TB. Next slide, please. The reason for suspecting probable TB in an ART center would be a child who is a close contact with a known case of MDR-TB, close contact of a person who died of TB, close contact of a person who has failed their TB treatment, a non-response or failure to first-line ATT, and previous treatment with second-line ATT. So if you have a child like this, and you feel that the child is not responding, then please send the child to a pediatrician for complete evaluation of MDR-TB. Next. So these again are the regimens. The principles of making a regimen remain the same. They will contain bedaquiline, linezolid, clofazimine, INH, and levofloxacin in some cases. Next, please. Now, what do you do? Now, with this, we have completed our talk about children and HIV and TB. We are now talking about TB treatment in people living with HIV in special situations. So the first special situation is if a PLHIV is on a PI-based ART. Till now, we have kept on talking if the patient's ART has a PI-based ART, then we should change the rifabutin to 150 milligram daily for the entire duration of anti-TB treatment. But suppose there is no rifabutin, then what will you do? If substitution of rifampicin and rifabutin cannot be done immediately, one should not consider super boosting of PIs in 1:1 proportion as in children. With higher ritonavir dose in adults, toxicities will be very high and hence they are not recommended. So we have to arrange rifabutin as fast as possible. Until that time, we should continue with rifampicin, but for a very, very limited time. Because if we continue rifampicin for a long time, it will make the boosted PI regimen ineffective and it will hasten the emergence of drug-resistant ART, drug-resistant HIV. So though we are not asking to super boost, but please do not delay it indefinitely also. Next. Now what to do with children who are on PI? Well, for children who are on PI, we can super boost. We can super boost lopinavir with ritonavir in 1:1 proportion. And if the child is more than 20 kg and age is more than 6 years, we can very well consider replacing the boosted PI with a dolutegravir based regimen with a double dolutegravir. Next, please. Now, what to do in pregnant women? In pregnant women, we have to understand that all drugs, HRZD, all the first line anti-TB drugs are safe. Second line injectables like amikacin, streptomycin are not used because they can affect the 8th nerve in the child, the 8th cranial nerve, the auditory nerve. Fluoroquinolones are not used in pregnancy because they can affect cartilage development. Ethionamide is contraindicated because it can have teratogenic effects. Bedaquiline and delamanide are best avoided unless and until it cannot be avoided, like there are no other drugs left, because the availability of data on the safety is very limited. We should also think that among the ART, dolutegravir or efavirenz-based regimens are safe in pregnant women, and they can have either efavirenz or dolutegravir regimen. And if desired, the woman can exercise opt-out option for dolutegravir and then continue with efavirenz-containing regimen. Next, please. Renal impairment we have already discussed. No dose required for INH and rifampicin. For pyrazinamide and ethambutol, you will give 3 times per week. Next, please. Now coming to TB iris, this was completion of ATT and ART. Now TB iris is a very interesting phenomenon. TB associated iris is actually nothing but paradoxical worsening of a PL-HIV with TB after starting ART. So what happens, there is a PL-HIV, he is diagnosed with active TB, he started on TB treatment, 2 to 3 weeks later he started on ART, and after an initial improvement, the patient starts deteriorating. So what basically happens in these cases is, there is either appearance of new or worsening of existing TB signs, and this typically occurs within the first 3 months of initiation of ART. And why it occurs is because there is an untreated TB infection in the body. Now that starts reacting with the immune, like we have the immunity of the body is built by giving ART. So whatever immunity is built, that starts reacting with a partially treated TB infection in the body, and actually after giving ART with improving immunity, the patient has worsening of clinical symptoms. So these are usually mild. They're sometimes also seen in HIV negative, and all they need is anti-inflammatory drugs with continuation of both ART and ATT. But rarely they can be very serious immunopathological reactions, as is seen in the case of meningeal TB, ARDS, massive adenopathy causing tracheal compression, and in such cases you might need to give corticosteroids. So this is something that we need to watch out, and for when we are treating HIV and TB, as it can occur in as many as 1/3 of patients who are given ART after giving TB treatment in HIV-TB cases. But CPT will be discussed in subsequent sessions. Coming to the last slide, next please. Well, finally, we come to the principle of prevention. We can early detect TB, we can appropriately treat TB, we can diagnose whether it is sensitive or resistant, give the right treatment, follow them up properly. We can declare an outcome, we can follow them up, but how to prevent? Unless and until we do not prevent, we cannot break the chain of transmission. So there are basically 3 ways of prevention. The first I. There are 3 I's. The first I is early detection of TB by intensified case finding using the 4 symptom complex, so that you pick up TB cases early, correctly put them on treatment, treat them to save their life, as well as take them out of the infective pool, which could keep on infecting other HIV positive. Number 2 would be giving a TB preventive therapy, which is currently the isoniazid preventive therapy. Isoniazid is one of the most effective bactericidal anti-TB drugs, which prevents progression of latent TB to active disease, also prevents TB reinfection, and its effects, the effects of IPT augment the effects of ART on reducing the incidence of TB. IPT does not promote isoniazid resistance when used to treat latent TB infection. Therefore, we can safely give TPT in any case of HIV who has in whom active TB has been ruled out. It is 300 milligram of INH given daily along with 50 milligram of D6 for 6 months. And the third most important component is airborne infection control. Next. So this is absolutely the last slide. The most important, a very, very important thing that we can do in our ART center is have airborne infection control measures in place. There are 4 kind of measures: managerial, which occur at the level of the administrators of the hospital; the administrative controls, and environmental controls; and PPE, which are at the level of the ART center itself. The administrative controls are basically nothing but maximizing your ventilation, and ventilation should be a mixture of natural ventilation. Open your windows and doors and use mixed mode ventilation with adequate fans and appropriately placed exhaust fans. The other thing that you can do is environmental controls. Environmental controls is nothing except social distancing of patients of TB from other patients, and also of coughers, of providing masks to TB patients and coughers who are waiting in the waiting area. And the third thing is to fast track the coughers and TB patients through the system so that they do not wait for a long time in the waiting area and infect other patients. And the fourth point is personal respiratory protection. In a setting of an ART center, it would essentially mean a respirator or an N95 mask for both staff and people attending the ART center, PLHIV attending the ART center. So next slide. So thanks. This was all about HIV-TB. I know it was a content-heavy talk, and I hope we were able to give you some insight into it. If there are any questions,
thank you.
Yeah, if there are any questions, I would be happy to take them.
Thank you so much, ma'am. Kiran, I now request you to please unmute the participants. Ma'am, there are some questions in the chat box. I'll take those first.
Yeah.
How to manage patients on third line in absence of rifabutin?
Yeah, that is actually a very good question, and we really don't have many options for what to do in the absence of rifabutin. As I told you that now hyper boosting is not really recommended. Super boosting of PIs is not really recommended because it causes a lot of side effects. And it is usually expected that you start the patient with rifampicin, and as soon as possible, you shift them to rifabutin. But yes, if rifabutin is not available in the field, there is nothing much more that you can do except for super boosting. But that would not be the recommendation.
Next question, how much super boosting with RTB can be done in such patients?
1:1.
Continuation, sorry.
1:1.
Oh, yes. Can we use levofox instead of ricin in such patients?
Levofloxacin, no, it's a second line ART drug. It's a second line ATT drug, and it should never be used in the first line. And it is specifically reserved for INH resistant TB and for other kinds of resistant TB. And in such a case, we would not recommend switching rifampicin with levofloxacin, because nothing can replace the action of rifamycin. Rifamycin is the only sterilizing drug in the first line ATT, and rifamycin has to be retained because it has been very clearly seen that any combination of first line ATT without a rifamycin is responsible for higher case fatality rates. So that would not be an adequate solution.
Next question, what is the duration of ATT, TBM and spine or bone TB? Sometimes given for quite a long duration in private.
Yeah, so this is actually a very, very important question. And Taina, again, I get the same question again and again. And I'm very happy to the participant who actually brought this to the foray. See, as per the national guidelines, and if you want to read more about it, there are index guidelines for extrapulmonary TB. For tubercular meningitis, the adequate duration is expected to be 9 months. But if you feel that the response is inadequate, or you feel that there is a possible of delayed response, that you can extend the continuation phase by another 12 weeks, which roughly works out to be 3 months, but that on a consultation of a neurologist. So for TBM, it would be 9 to 12 months, the 12 months being the extended part. For all bone TBs, including spinal TBs, the minimum duration is 12 months, which can be extended to 18 months on the expert guidance of an orthopedic surgeon. So for TBM, it would be 9 to 12 months. For spinal TB and bone TB, it will be 12 to 18 months.
Why is ATT measured in weeks instead of months? ATT is dispensed for 28 days, but ART is dispensed for 30 days.
Correct. So there is no hard and fast logic behind it. It is basically based on all the studies that were done in this area in the field of ATT, in which ATT was taken in weeks. And secondly, it is the packs which are there for 28 days, the drug dispensing packs which are made for 28 days. So it is a combination of logistics and the literature available on ATT that it is measured in weeks.
Ma'am, there's a comment in continuation with the Levofox drug. It seems there are TB experts who give Levofox for PI-based regimens.
Now this is, I would say under the national guidelines, it is not recommended. That is all I can say, because Levoflox can never replace the results of rifampicin or rifabutin. So I am not sure. These must be good experts in the field, but it is not recommended under the program.
Thank you, ma'am. We'll now take questions from the participants. Participants are requested to please unmute their mics if they have any questions.
I would just like to add another thing. If for some reason you cannot give rifampicin, then just replacing with levofloxacin is not the solution. Then you would have to consider it as a regimen in which rifampicin cannot be tolerated or rifampicin is resistant. Then you will have to go all the way. You can't just replace it with one levoflox and say that we have an effective antitubercular therapy.
Yeah, there's one more question in the chat box. What is the size of L node in abdominal TB?
What is the size of lymph node in abdominal TB?
Yes.
Yeah, so actually abdominal TB is a very complex thing to diagnose in patients with HIV, but it is very frequently encountered. So what I would say that any lymph node which is more than 1.5 millimeters, 1.5 centimeters in diameter, showing a central necrosis on ultrasound, and possibly showing some other evidence of active TB disease like matting of lymph node, some ascitic fluid, or some thickening of the bowel loop. So if you have multiple lymph nodes with sizes more than 1.5 and the patient is 4S positive, I think we would have to go in for a TB treatment. But if we do not have and something very clear on ultrasound is a central necrosis, please ask your ultrasonologist to report whether there is central necrosis in the enlarged lymph node. Extensive lymphadenopathy with lymph nodes, some lymph nodes or many lymph nodes more than 1.5, with a central necrosis, with matting, thickened bowel loop, ascites. So it's a permutation and combination of symptoms and ultrasound, findings by which we have to reach on the diagnosis of abdominal TB and PLHI.
What is the treatment for hepatitis B patient?
That I think would have to be
I'm not sure if it's related.
Yeah, and the hepatitis talk, I think it could be taken up.
Right. Any questions from the participants? What if the abdominal TB, that is patient is sputum negative, what might have caused abdominal TB? If a patient is sputum negative, what might have caused abdominal TB?
All extrapulmonary TB is caused either by blood or by lymph nodes, but in this case, it could be able to reach the abdomen through mycobacteremia. There's always a mycobacteremia, but there's a high level of mycobacteremia in people living with HIV, even if their X-rays are normal or the sputums are negative. That is a manifestation of the immune deficiency.
Madam, I am Dr. Kaur from MKCG Medical College, Odisha. What is the rationale in giving INH to a patient who has just completed 6 months of anti-TB treatment?
Yes, sir. Right. So this is a very important question, very often asked, and the answer to it is very simple, sir. The duration. First and foremost, the chances of relapse of TB in a patient who has already suffered TB are very high within the first 2 years of completing treatment. So if there is a TB patient who has just completed TB treatment, his risk of TB is really very high the first 18 months, if 6 months we include of the TB treatment. So first 18 months, number one, the risk is very high. Secondly, the data that has been available on INH prophylaxis around the world, if you would see the analysis, we have taken 6 months in good faith and based on the duration of IPT as 6 months based on a lot of literature, but there is no hard and fast study that says that 6 months is it. There are certain recommendations of WHO which say that IPT should be given at least for 36 months to be effective, or maybe even lifelong in people with HIV. So considering this literature, these two evidences on the TB side and the IPT side, it has been decided that patients who have just had TB, they need additional TB preventive therapy to bring down the risk of additional TB in the first 18 months. That is why we give them IPT for another 6 months. Now, whether this 6 months, 6 plus 6 is adequate or not, that is still to be seen. It's a matter of operational research and clinical research. But till now, we are giving it for another 6 months.
No, another question. All cases of tuberculosis, those who are on TLD, we give in HIV, we give an extra dose of dolutegravir for another 2 weeks after the stoppage of the anti-TB treatment.
Yes, sir.
Does it actually, is it that the effect of TB ATT remains for another 2 weeks?
Sir, it is not exactly the effect of ATT, but the rifampicin-induced CYP induction, the CYP induction that happens due to the rifampicin doses, that takes about 2 weeks to come down to normal. That enzyme system which has got induced, for it to come down to baseline, it needs about 2 weeks.
Thank you. Thank you, madam, so much.
Thank you.
There's a question in the chat box. If a patient is having EPTB, has been diagnosed MTB positive by FNAC, has been treated for 6 months, his symptom primary has subsided, do we need to redo FNAC for confirmation of MTB negative in that patient?
No, there's no need for resampling lymph nodes. The only time we resample a lymph node is if it is showing some signs of IRS. Like the patient is clinically improving, but the lymph node is increasing, it is becoming red, swollen, there is pus inside it. That is the only time when we resample a lymph node, when we want to send cultures to see if there is any live bacteria left in our lymph node, but otherwise there is no need to resample that. It will be a clinical follow-up and a clinical diagnosis at the end. Treatment completion at the end.
Thank you, ma'am.
So, madam,
yes, sir.
Can
yes,
I speak?
Yes, sir.
Madam, in extrapulmonary tuberculosis, specifically in lymph node tuberculosis, in lymph node tuberculosis, we give treatment for same 6 months.
Yes, sir.
But most of the patients actually, they do not, they still have the ulcer, they still have the node, they still have pus coming out from that, not pus cageting material coming out from that. 25 years back, madam, 25 years back, I had done a paper on lymph node tuberculosis, short-term chemotherapy in lymph node tuberculosis, and that was published in British Journal of Surgery.
Okay, sir.
But before, from 25 years, not even 25 years, it will be probably more than that. It may be 30, 32 years about. But still then, the same 6 months of treatment continues. But the patients do not actually have much of a clinical improvement.
Yes, sir. So, sir, in this case, if you feel that your patient is not having a clinical improvement, you are well within your right to extend the ATT. The continuation phase of the ATT can very well be extended for about 6 to 12 weeks if you feel the patient has not got sufficient clinical response. But having said that, just a continuous swelling or redness of lymph node is not indicative of the TB not improving. It probably means the inflammation is ongoing in the lymph node, even if TB has subsided. So in such cases where we see that patient is nearing completion of treatment, but still lymph node is large, in such cases we re-FNA the lymph node and we send it for culture. And if in liquid culture, and by the end of treatment, we would have the result of the liquid culture. If the culture is negative, that means it is now only an inflammatory response and you can actually get the abscess drained and the patient's TB is gone. But if the culture is still positive and it continues to be sensitive to all drugs, you are well within your right to increase the continuation phase of the antitubercular therapy.
CBNAT will not help at this stage.
No, sir. CBNAT always can easily pick up dead things. But in lymph node, we want to know whether it is whatever persistence of even microscopy does not help in lymph node, because whatever we want to see is whether it is the dead AFB that got trapped within the lymph node, or is it a live bacilli. You can continue to have dead bacilli for a very long time, even after TB has been healed, because there is hardly any place for the TB bacilli to go away from the lymph node unless it is slowly removed by the lymph node system. But if it is alive, you are well within your right. If it is growing on culture, you are well within your right, sir, to increase the continuation phase.
Thank you so much.
Ma'am, there's a question in the chat box. A patient who has received a TPT gets TB, then gets treated for it with ATT. Do we have to give TPT again?
Actually, this is a very good question, and I don't have a very good answer for it. But as of today's guidelines, IPT or TPT is to be given only once in a lifetime. Though I cannot predict what would happen in the future, this question makes absolute sense that if the earlier TPT, despite the earlier TPT, patient got TB, so that means his protection is not adequate. And in a logical sequence of events, we should be repeating it. But the current guidelines say that we give TPT only once.
But I'm sorry, I've got another question also.
Yes,
if you
sir.
don't mind.
I don't mind,
Ma'am, previously, when we are treating, we were giving ATT, first 2 months of IP, after 2 months, completion of 2 months of IP, we are going on for a sputum examination again, for sputum IFB. And if it comes positive, we were extending the IP for another 1 month.
Yes, sir.
But now, as here in RNTCP, they say that, that it's not necessary to increase the IP again. This treatment to continue and for another 4 months of CP,
yes,
and everything will be okay.
So actually, earlier what was the problem was that we did not have resistance testing tools in the program. So we were just diagnosing people on the basis of sputum microscopy. We did not know whether they were sensitive to rifampicin and INH or whether they were not. So we were doing the sputum microscopy, and if we were in faith giving everybody first line, and if they did not become negative at 2 months, we were extending and then going on. But now with the availability of CBNAT and DST for everyone, we expect that if a patient is sputum positive, we should be able to type whether it is a RIF resistance or INH resistance in a timely manner. Yes. Now, if the patient is RIF resistant or INH resistant, then the question of extending IP doesn't arise. The patient goes for DRTB. And if the patient, DRTB treatment, but if the patient is rifampicin and INH resistant together or in isolation, then if the patient is sensitive to rifampicin and INH, then we would expect that extension of IP is no longer needed. We should continue with the CP.
Even if the sputum is positive after 2 months of IP?
Yes, sir, because the problem is not with the drugs now, because they are still at the end of 2 months also, they are sensitive to INH and rifampicin. So if they are sensitive to INH and rifampicin, continue with your CP. And if in the CP also the patient doesn't respond, then he has failed. But if the patient is responding in CP, then you say, what I'm trying to say is that extension is no longer necessary because we have availability of R and H sensitivity upfront.
Thank you.
There's a question from the chat box.
Yeah.
Do we give IT in TB cured PLHIV? If yes, when?
Yeah, we do. We give it for all PLHIV, whether they are cured or treatment completed. And we give it like we give for every other patient who has TB, and then we give IPT for secondary prophylaxis. If today I have finished my TB treatment, I am successfully cured in TB, then from the very next day, my IPT will start for another 6 months.
Next question from the chat box. What might be the solution to improve outcome of MDR TB?
I think that's a whole session in itself. MDR-TB, there are so many drugs and like there's so many permutations and combinations of resistances. And if a patient is resistant to all the group A drugs, which is the most efficacious drug, that is bedaquiline, linezolid, and levofloxacin, or for some reason he's not able to take that drug because of side effects, then yes, efficacy goes down, the efficacy of treatment goes down. But I guess the answer to having better MDR-TB treatment is newer drugs, better regimens, early diagnosis, appropriate treatment, early management of ADRs, and a very stringent follow-up.
In the absence of rifabutin, when patient is on a PI regimen, can we not put them on DTG-PD?
Yes, you can put them on DTG. As I said, you can put them on DTG if they have not taken DTG earlier, or they have not failed a DTG regimen. Then you can very well put them on DTG. That is absolutely the first choice to be done.
Thank you so much, ma'am. No more questions in the chat box.
Okay, thank you.
Sorry, ma'am. There's one. The simple surgical mask or N95, which one protects us from TB?
See, so this question is interesting. Give the patient a surgical mask for the simple reason that when the sputum is at the source, at the patient is the source of the sputum or the infection, the droplet is big in size. So for a big droplet, a surgical mask is enough. But once it has come out into the environment and it has become an aerosol or a droplet nuclei, then it can no longer be contained by a surgical mask. So people, the healthcare worker and other people who are trying to prevent themselves from getting TB need to wear an N95. So the patient needs to wear a surgical mask to prevent giving it to others, and other people need to wear an N95 to prevent getting it.
It's not true for COVID virus.
Pardon, sir?
And if we want to protect ourselves from COVID virus, and the patient should wear a N95 mask also.
So that is actually you can also prevent if the patient wears a simple surgical mask and wears two of them. There's a certain degree of protection. Actually, a surgical mask is N85. So N85 तो हो ही जाता है उससे.
Thank you, ma'am, for the excellent
For
session.
the discussion, madam. Thank you so much.
Sir. Thank you, sir.
Thank you, ma'am, for the excellent informative session. Thank you, Puri sir, for joining us for the opening remarks. Ma'am, can we go ahead with the posters now?
Please go ahead. I know I've taken a lot of time. It was such a huge.
No, thank you, ma'am, for your time. Thank you very much.
Thank you.
Kiran, can we have the e-poll now for the post test? Participants are requested to please attempt the post test questions. There are 7 questions in all. The post test is now visible on your screen. Please scroll through the questions and attempt the e-poll.
Shweta ma'am, poll is visible.
Yes, Kiran.
Okay.
Participants are requested to please attempt the e-poll.
20% people have answered.
Yeah, we can end the e-poll now, and please share your screen.
Okay.
First question. The answer to the first question. The question was, which of the following is not true regarding HIV-TB co-infection? The answer is TB is most common OI in PL-HIV after PCP. Next slide, please. Question number 2. PL-HIV must receive dash preventive therapy for the entire duration of TB treatment and beyond till CD4 count crosses more than 350 cells per milliliter and sustains at that level even beyond 6 months. So PL-HIV must receive cotrimoxazole preventive treatment for the entire duration of TB treatment and beyond till CD4 count crosses more than 350 cells. Next, please. Which of the following is the most appropriate measure for the PL-HIV with presumptive TB who are found to be RIF sensitive on NAT? The answer is start ATT and send a sample for first line LPA. Next, please. Which of the following ATT drug is known to cause retrovilbra neuritis? Ethambutol. The answer is ethambutol. Next, please. Which of the following statement is not true regarding HIV-TB co-infection? The statement that is not true is, among PL-HIV with TB meningitis, ART should be started as soon as possible within 2 weeks of initiating TB treatment, regardless of the CD4 cell count. Next, please. Which of the following is the most appropriate action regarding management of TB diagnosed in patients already receiving ART, AZT, 3TC plus efavirenz and ATT, 2-HRZE plus 4-HRE daily regimen? So the answer is there's no change required in ART regimen. Next, please. Which of the following is not a group C second line anti-TB drug, that is bedaquiline? Thank you so much, Kiran. Can we have the feedback e-poll now? Participants are requested to please attempt the feedback questionnaire. There are 4 questions in all. Please scroll your screen and answer all the 4 questions. Kiran, we can end the e-poll now. Once again, thank you, Upasna ma'am, for joining and for this informative session. Thank you to all the participants for patient listening. We'll close the session now.
Thank you so much.
Thank you so much, ma'am.
This is a presentation.